of marriage. 4 years, 6-month-old girl, third by birth order, born out of non-consanguineous marriage, resident of Chembur, hailing from Bhopal, Muslim by religion, Hindu by religion, right-handed, brought by mother with chief complaints of fever since 1 month on and off, one episode of paroxysmal event 1 month ago, weakness of the right upper limb since 28 days, and weakness of the right lower limb since 15 days. She was all right 1 month ago when she developed a fever, which is mild grade, undocumented, not associated with chills, rigors, or rash. The fever subsided on symptomatic medication but would recur on and off. 2 days later, she had a paroxysmal event in the form of tightening of both hands, feet, and uprolling of eyeballs, which lasted for 2 minutes and resolved spontaneously. This was followed by a period of postictal drowsiness of 2 to 3 hours. The child was afebrile during the event. The mother did not seek any medical attention for the same. The child also complained of headache, which was intermittent in nature, frontal and side, dull aching in character. 2 to 3 days later, the mother noticed drooping of the right
I'm
shoulder.
sorry to
The
disturb,
weakness.
but slides are not moving.
She's still on the first slide, madam. Hello, madam?
Yes, sir. Slides are not moving.
No, so this is the first slide.
Okay, okay. Then it's okay, sir. Thank you.
Which one she said? What is being seen on your slide?
Thursday clinic, Dr. Purnima Laveti.
Okay, sorry.
Yes, now it's third screen. We can see third slide.
Okay.
Yeah.
Two
Thank
to
you.
3 days later, the mother noticed drooping of the right shoulder. The weakness was gradually progressive, and over the course of the next 4 to 5 days, the child was unable to lift her arm over the head and was unable to hold the pencil and write properly or feed herself. The mother also noticed that the child began dragging her right foot, had slippage of slippers in the right foot approximately 13 to 14 days after the onset of right shoulder weakness. She was unable to get up from the squatting position without assistance. She was able to get up from the supine position by taking support of the left side and could lift her head above the level of the bed while lying down. The child also started using her left hand to carry out her daily activities after 15 to 20 days. For these complaints, the mother initially took the child to some local practitioners and was given routine massages. She was advised neuroimaging by another practitioner and underwent the same, following which the mother brought the child to Sion Hospital. There was no history of altered sensorium or vomiting, no history of any tingling sensation or numbness, no history of bowel or bladder involvement, no history of any involuntary movements or swaying, no history of excessive sweating or palpitations, no history of blurring of vision, no history of abnormal eye movements, double vision or drooping of eyelids, no history of difficulty in chewing, no history of difficulty in closing her eyes. There's no history of regurgitation of feeds, nasal twang, or difficulty in swallowing, no history of difficulty in shrugging her shoulders. There's no history of any bleeding manifestations, no history of Cox contact, no history of cyanosis or dyspnea, no history of any skin rash, joint swellings or joint pains, no history of any head or neck trauma, no history of decreased urine output, oral intake or loose stools, and no history of similar events in the past. Antenatal history, registered pregnancy, antenatal scans were normal. Supplements and TT injection were taken. No medical or surgical complications. Birth history, she was a full-term normal vaginal delivery. The baby cried immediately after birth. The birth weight of 3 kgs. No history of an ICU stay. She is immunized till 1.5 years. Developmentally normal. Age-appropriate milestones have been achieved. And dietary history, she consumes a mixed diet from the family pot. The family history was not significant. Socioeconomic history belongs to lower socioeconomic class according to modified Kuppuswamy scale.
Good. Pallavi madam, can you hear us?
Yes, sir. Yes, sir. You
Okay,
are
thank
audible.
you. Thank you.
But the slide is third only.
Yeah, we went back to
We went back.
Okay, sir.
Yeah. Okay. So take the first para. She was all right 1 month ago when she developed the fever. What do you make out of this? Do you have any questions? Do you have any clarifications?
in spite of the fever, how was the child?
In spite of the fever, how was the child? Was he active? Was he feeling well? Uh, was he playful?
Anything else? The point I wanted to make is that this is low grade fever, mild grade and undocumented. So this active, playful, all that relates to high fever. Okay. Secondly, when we use the word the fever would subside on symptomatic medication but would recur on and off. This usually suggests a long history, meaning we would use these words for 10-15 days of history. But if we understand right, you are saying that there was 2 days of mild fever and third day this happened, no? Whatever
She had
happened.
fever on and off since 1 month, and she had that paroxysmal event 2 days after the onset of fever.
Correct. So you're saying that all this 1 month that low grade fever on and off has been continuing, and from the onset 2 days later this happened. Okay. So there's 1 month of fever as of today, from the day it started, and it's low grade on and off. So what do you make out of it? Come on, we've discussed this many times, so this should come reflexively.
Low grade inflammation.
Low grade inflammation, okay. So is it infection?
Could be.
Could be. What kind of infection? Acute bacterial, acute viral, chronic bacterial, chronic viral.
Tuberculosis.
So chronic bacterial tuberculosis you want to keep in mind. You're
You're
sure it
sure it
is
is
that, or
that
it could be
it could be non-infective also.
why?
Immune mediator.
No. Non-infective is immune. In here, why are you saying it could be non-infective? There should be some basis, no logic. Theoretically, yeah, it could be infective, non-infective. You have to choose between the two.
It's low grade and no localization.
Localization.
Okay, so chronic infections don't localize.
Vasculitis.
So vasculitis is a cause of non-infective inflammation. One is what kind of fever does vasculitis usually cause? And what I am trying to ask is, besides fever, what are the other manifestations of chronic infection? So some constitutional symptoms. So that may help you to try. You may not be able to finally decide, but that's the way to dig. Is there any change in appetite, weight, this, that, etc.?
I think, sorry, Mike. Uh, all that we know is that there is a low-grade inflammatory problem. We won't know anything more than that. You can add one more adjective, that is having no other symptoms whatsoever. So 1 month of a low-grade fever, but without any symptoms. Now, it is at this point of time that you should have asked the mother upfront whether there was any loss of appetite, loss of weight, loss of activity, energy, weakness. Okay, this is the most important part. Suppose she said, no, no, he was fine. Then you start wondering whether low-grade fever is really worth a discussion. But on the other hand, she says, yes, I think he was looking a little low. He would not go to play. Still, we know that it was really a low-grade fever. So first confirm that it has affected the health or the routine activity of the child, which tells you that it is a persistent low-grade inflammatory disorder. Now, if it is persistent low-grade, then it is less likely inflammatory. It is more likely an infection. So then medicine most likely and less likely need to be considered, but by priority. So now we are considering a low-grade infection. And I imagine it must have affected the routine of this child. We presume that. Okay. But this is what we wanted. How would you have asked this question? Only you would have started thinking after the first symptom, what comes to my mind? Okay. And therefore, we have always been saying that history taking is a thought in action. You ask a question by thinking what next question you should be asking, not the sequence of what parents talk about, right? So we talk only about that. Could it be non-inflammatory disorder? Doctor? Keep that in mind. What is low-grade fever? Low-grade fever may be no fever also. It's not documented. So we keep that in mind. Could it be a malignancy? Low-grade fever. Okay.
Constitutional symptoms would
So the
be
point is that malignancy may come even without fever. It may come with low-grade fever, a low-grade Hodgkin's lymphoma.
Also, you should look at the mechanism of fever in a malignancy. So, for example, low-grade fever in a malignancy is often because of a lot of cell breakdown. Okay. Now, if there is a lot of cell breakdown, the general condition in that 1 month will start getting affected. So, you will get other constitutional symptoms.
In fact, low grade would mean that there is a very low grade cellular damage. And a tumor may have a low grade cellular damage. Okay. You want to say?
He's checking on the recording.
Oh, okay, okay, all right. I'm sorry. So I think at the first paragraph, we are not sure what we are dealing, but our first priority is a low grade infection. Now the question is, could it be a fungal infection? Low grade. So now we want to know straight away how has it been all along. Okay, so unlikely fungal infection. Okay, could it be a parasitic infection? It could be low grade, off and on. Could it be malaria? Could it be cholera as well? So generally not low grade fever, but it depends on the epidemiology. And a place where there is so common uh, epidemiologically a malarial infection, people will have probably even no fever with malaria. So we keep all that in mind. In other words, we need to ask about the environment, the type of illnesses present in that epidemiology. All this would be important, but mostly not of any other kind, right? That is what. Let's take the next step.
So 2 days later, she had a paroxysmal event. So now someone to analyze this paroxysmal event.
So 2 days later is a month and 2 days later.
No. Onset of fever and within 2 days. Today it is 1 month of the whole story. So try to analyze this event and whatever we can make out of this.
First, mostly looks like an unprovoked event. Child was afebrile, bleeding, and tired.
Put it on post and see.
So it looks like an unprovoked event. As it's mentioned, child was afebrile during the event, and the generalized tonic-clonic seizure which lasted for 2 minutes. However, the post-ictal drowsiness is of 2 to 3 hours.
So post-ictal drowsiness is 2 to 3 hours. So is that a problem? Not a problem? Any thoughts? Come on, simple.
Causes of conversion, so we should
Do not.
follow have a post-ictal drug.
Do not. But here it is long. So what would come to your mind? Hmm?
Infective or inflammatory?
Why infective or inflammatory? I'm asking, is there any connection ke infective or inflammatory has a lot of post-ictal drowsiness following a seizure? Means, see, to a situation where somebody presents with a seizure and then continues to remain altered is something like a viral encephalitis starting as a seizure and then altered. That's a different issue. But a post seizure 2 to 3 hour drowsiness doesn't mean anything. So again, what I would look at it is first I would confirm whether it's 2 to 3 hours. It looks very out of place. And then after 3 hours, was the child back to original or remained altered? Because then it's a milder version of that first situation of the encephalitis kind of encephalopathy persisted. So that's what you need to check. After 3 hours, whether it was totally normal. The second thing is always now we have learned all this. So the parents call it generalized. But what should we always check?
How did it start?
If we can get a micro detail of exactly how it started. So focal onset with secondary generalization, we may not get it on history, but we'll have to check on that. And would you have called it a febrile seizure? Suppose he had that low grade fever at that point. It's written afebrile, but suppose he had low grade. Second day of illness, so atypical febrile seizure. So that is common, but is that a rule? Febrile seizures can occur at any fever, even low fevers. So would you have called it febrile? So the point is that the first time in life, febrile seizure at 4.5 years age is very funny. So somebody who has febrile seizures would have it at 1 year, 1.5 year, etc. So for multiple reasons, you would not call it a febrile seizure, and you would look at something else.
If we take 2 days as 48 hours, then which convulsions after fever comes 48 hours later?
Meningitis. Meningitis.
Meningitis. So could this not be meningitis? 4-year-old. Okay. Typical meningitis.
So the fever would be high grade,
Low grade fever, tuberculous meningitis.
sick looking child. Meningitis.
In other words, yeah.
Always complains like irritable, altered
But thereafter there is some headache coming. So is it not enough to say there is a headache, there is a raised ICC, convulsion coming 2 days later is a typical bacterial meningitis. And there is some encephalopathy maybe after a seizure, and therefore classically a tuberculous meningoencephalitis.
So for that seizure, they did not seek any medical attention, which may tell us that it was not.
Well, TB meningitis may have a seizure which is self-controlled, but the rest of the disease is not self-controlled. That's what is happening there. Okay, headache has come up. Drowsiness has remained for a long time. So the brain problem continues. Seizure has stopped. And majority of the seizures stop. Okay. Very few run into status, but otherwise majority of seizures stop.
So for a moment, speak out a classic story of bacterial meningitis in a 4.5 year old. Speak it out and see what is different. And speak out a classic story of TBM and see what is different. Start classic story of bacterial meningitis in a 4.5 year old. High fever, irritability, vomiting, and then a seizure. So sequence, vomiting and headache has to precede.
So I would put it tuberculosis meningitis.
So now,
So that all acuity is gone.
But in many days, fever would happen for many days.
so longer duration of fever, then
Constitutional symptoms.
so constitutional symptoms, so not perfectly all right before the onset, then so some change in behavior in the first 2 days before the
But
seizure.
if you see a tuberculosis meningitis, typically, younger the child, more of an encephalopathy. Older the child or an adult, less of encephalopathy, more of meningitis. This child is towards the younger one. So he should have had not headache, okay, not irritability, but more drowsiness, seizure. So that headache is unusual for a TBM. Well, we need to know more about headache, how severe it was, whether it was associated with vomiting. Then headache and vomiting together may have a significance. Otherwise, headache alone may not have any significance. So we have many. This is the importance of going into details of history. Okay, so we will not be able to make out much about all this, except to say that this is some infection which has now caused some, but we don't know how that infection has caused it. For example, a tuberculosis infection does not result with some more symptoms because the infection has spread. Infection may not have spread, but the disease has spread. How can that be? You get my point? Bacterial meningitis worsens when the bacteria keep on multiplying and the patient is getting more sick. But tuberculosis meningitis, the bacteria may not be multiplying, but the patient may get more sick. This looks one of those.
The host response.
Or in other words, it's an immune complications that is occurring. Whereas in a bacterial meningitis, it's just the bacterial multiplication itself. So we keep all that in open, and therefore we do not. But what is more important is headache is intermittent headache. We would have been happy to see how severe is the headache. Okay, headache is unusual in this child. Okay, we are not looking at a much of raised ICT. We are not looking at any tumor there, but we need to get all those details, right?
And now 2 3 days later, drooping of right shoulder, gradually progressive and over next 4 5 days, unable to lift her arm over the head and unable to hold pencil and write properly or read.
I've seen drooping of eyelids. I haven't seen drooping of shoulder, right? What does drooping of shoulder mean? So he's almost doing that. So where is the anatomy of this drooping of shoulder? Is that my question?
Come on. Sir is asking the drooping of shoulder happens due to what?
The question put the other way is what holds my shoulder straight?
Spinal.
So the trapezius is okay. When my trapezius is weak, my shoulder is going down. So is it a localizing symptom? If the story is right, it has not started with not able to move the leg. It has started with drooping of the shoulder. So is it that the trapezius is coming up as the first symptom, localized? Thereafter, of course, progression has occurred. So keep all that in mind. Drooping is a little unusual symptom to be complained of. Most of the neurological problems like this would say he stopped using his hand. Here the mother has noticed drooping. And then over the next 2 3 days, this weakness started progressing. So we take a note of that. But thereafter, he is unable to lift her arm over the head. Okay. Which muscle is involved? We thought trapezius is involved first. Now which muscle is getting involved? Deltoid. So you can see that the whole story seems to be gradually progressive, which means right up there in the brain, this must be happening. That areas are gradually worsening or getting upset. And I think that is what is. And then he's unable to hold a pencil. So that means the whole hand is coming. What do you make out of this? Shoulder first, the deltoid later, and thereafter apparently even the distal part of the limb. So we believe that the whole right upper limb has been involved. But look at the progression. If somebody has noticed it, I think it's something wonderful. Not easy for even a doctor to ask all these questions. So what do you make out of it?
You can make positive or negative comments.
So could it be a muscle disease? Because the trapezius, we have a deltoid, we have a peripheral muscle.
Unilateral goes against it.
Sorry?
Unilaterality goes against it.
Against?
Muscle disease. It belongs to a specific vascular territory. They belong to a specific vascular territory.
So anything about vascular, do you think it's a vascular pathology? So vascular usually happens all at a sudden. So this is gradual. So which vascular can happen gradually? Thrombosis. Okay. And are we sure it is at the central level or this is spinal? Because there was a seizure, we are connecting it and calling it central.
But suppose there was no seizure, then you would still call it, then you would entertain the peripheral, or you would still say no, it's more likely central. Spinal can be unilateral.
So how would you rule out spinal then if there is no seizure at all?
Does the progress tell you anything?
It's fine, everything is compact, they're very close to each other. So this kind of gradual increase or slow progression is unlikely to be spinal. And to that extent, your answer about unilaterality also holds because the spine is so narrow over there. Any lesion, if not directly with indirect edema or compression, may have some manifestation of
In
this.
typical spinal may have pain because the sensory system is also involved. And therefore there could be pain, there could be some other sensory involvement. So this is not spinal. So even without a seizure, it must have been coming up from.
Then the mother noticed the child began dragging her right foot and slippage of slippers in the right foot 15 days after the onset of the shoulder weakness and unable to get up from squatting position without assistance. So now what does this suggest? Progression to involve the lower limb. Okay. And it's happening over a longish period of time.
Is that a sensory problem? Slipping of foot? Is it motor?
Why motor? And what's happening? Why are the slippers slipping? So the peripheral muscles or the distal muscles are getting weak. Okay. She was able to get up from supine position by taking support of the left side and could lift her head above the level of the bed. Using her left hand. Okay. So now all we know is that the problem seems to have progressed and it is a slowly progressive hemiparesis or hemiplegia, hemiparesis
So
of the
why
right side.
vascular? Vascular doesn't progress over 15, 20 days. Even a thrombosis would not take a long time to progress. So it must be a tumor. It must be a growth.
She's saying there are no signs of raised ICP.
there is a headache. And if the tumor is at a small place to begin with, it's slowly enlarging. They only not enough to cause brain ICT. Okay. You have a tuberculoma or a neurocystic sulcus coming only with season. Okay. But vascular is out. Okay, it takes 15, 20 days. What kind of thrombosis? It's taking such a long time to kind of manifest. Thrombosis takes few hours. Okay, hemorrhage or embolism maybe even few minutes. But that is all. So could it be vasculitis? Yes. So one vessel only gradually worsening, or do you think it's a multiple vessels exactly? So what's the etiology, possible anatomy of that seizure? We are focusing on that.
So also when you're talking about vascular, so which vessels are involved? Are you thinking of arteries or you're thinking of veins? The arterial affection or venous affection? Arterial. So if it's arterial, which artery are thinking? Is it a basilar system affected, or it's a middle cerebral, or it's an anterior cerebral? What are we thinking? Middle cerebral artery. Okay. So internal capsule. You can start from below actually, medulla, pons, midbrain. Not thinking of that, right?
Internal capsule would have
Correct? Absolutely. So that's again we have to still go further up. Also, we also already have seizures. So if you have seizures without raised ICT, without hydrocephalus, the lesion is unlikely to be below the subcortical, cortical or at the most subcortical. So now we are left with something above the internal capsule. It could be coronary data or on the front lobe.
Could it be moya moya? It doesn't look like one vessel causing all this. The progression looks something different. So could it be multiple small capillaries getting involved? Could it be moya? You are thought. Okay.
So fever, can it be seen as a inflammatory response? So I was just thinking that even in Moya Moya, multiple vessels, but each vessel should have been a relatively sudden event.
So
Here this,
multiple spread out. This is only on one side. Okay, Moya could involve any part of the thing, but each time a sudden appearance of a new symptom. This doesn't look like sudden. This is progressive from same focus, getting on to a kind of extension of that focus in the same area. So it's not a multiple vascular disorder.
and also when we're talking of a tumor, so what is the representation of the legs and hands on the cortex? So what I'm trying to say is for the lesion to spread from the hand to the leg area, it's a fairly big area. So for a tumor to get so big in 15 days is also funny without other symptoms, right?
No bladder involved, right?
No.
Provisional diagnosis: a 4-year-old girl, birth and developmentally normal child, immunized, partially immunized, brought with complaints of fever, seizure, and subacute onset progressive right sided hemiparesis. Is most probably a case of vasculitis or space occupying lesion or a thrombotic stroke involving the left cortical middle cerebral artery territory. On examination, the child was conscious, oriented to time, place, and person. She was afebrile with a pulse rate of 108 beats per minute, regular, normal in volume and character, respiratory rate of 28 per minute, saturation of 99%, all peripheral pulses are well felt, blood pressure of 100 by 60 mmHg maintained, sugars are maintained, pallor is present, no cyanosis, clubbing, or lymphadenopathy. Anthropometrically, weight was minus 2 standard deviation. Height was 92 centimeters, which is less than minus 3 standard deviation. Head circumference is 49.9 centimeters, minus 1 to 0 standard deviation. Mid upper arm circumference is 16 centimeters. Weight for length less than minus 3 standard deviation. Impression was severe acute malnutrition. Head to toe examination. Head was normal, no dysmorphic features, eyes, ears, and nose are normal. Trunk, abdomen, normal. Spine and genitalia were normal. Central nervous system examination. She is right-handed. Higher mental functions were preserved. The child is coming.
Come. Sir, I'll get it, sir.
Is the behavior like a normal 4-year-old? In front of so many of us, you look very confident.
Purni, just please, block your video for the time being on that Zoom.
Start talking from a distance.
Okay. Anjali or Pallavi madam, can you put on my video?
Yes, sir. Your video,
Yeah, yeah. Okay.
your video is on, sir. Your video is on.
Yeah, yeah. Okay. Thank you. Thank you.
Pallavi, can you pin Rajesh's video?
Okay, just a minute, ma'am. Done. Yes, sir. Done.
So my first question is, I heard something about severe acute malnutrition. I heard something. I was going to answer the phone. The background may I heard. So comment on that.
4-year-old was 12 point something kilo and 92 centimeters. So what's the normal weight of a 4-year-old child considering 2.5 at birth?
16. Okay, so 12 kg is what weightage? 2 years. 2 years. And 92 is what height age?
3 years.
3.5.
They
3
say
years
3
is
years.
3 years is
3 years.
94. So 92 is 2.5 years. So weightage of 2 years and height age of 2.5 years. Is it chronic malnutrition? She looks malnourished. So whenever weightage and height age are very close to each other, think constitution. Okay. She's given C right. That's
Do
why
you believe it's constitutional? Probably that's a mother. So what constitutional? What's your comment?
Father would be very lenient.
So constitutional doesn't mean that the parents are obese, but the child is still yes, because the parents must have been in during their childhood. So that is still possible. So leave it at that. Come, talk something beyond that. So we know that it's not a very much malnourished child. Well, it may not be fully normal nourished. That's fine. What else? Just observation first. We said growth. Comfortable, sick, acutely sick, chronically sick, very comfortable. What does that mean? We're talking about all vasculitis, progressive, okay, and the patient is comfortable. What does it tell you? Why is this patient so comfortable?
Waxing and waning of the disease.
In other words, the problem that has triggered has not been fastly worsened. And even the immune complications or whatever we are thinking are not worsening progressively. So it's a slow progression or may have not also stopped progression. Okay, so that. But I'm sure this child has received a lot of steroids. Agreed? No, she doesn't agree. But you agree, right? I can see the baggy cheeks. Look at that. It's the steroid phase. So now you both fight and we will enjoy the fight. Come on.
Come on, come on. Sorry? No, in this month, suppose she's got steroids.
Suppose she's got
So does her face look like she's got steroids? Is the question sir is asking.
That's why she's not looking like Sam, though she is Sam actually. That's what it is.
So with some
And
resemblance.
I thought she was so comfortable,
Happy,
almost
cheerful.
euphoric.
Yeah,
She was very happy coming. So you have a euphoria and the baggy cheeks. What more you want? Steroids.
Come on, come on.
So the cheeks resemble the mother.
Yes, so I don't think the cheeks are like what you see in a steroid faces. It's not that big.
And look at the mother also. Similar kind of constitution. And what else would you see? She must have received a steroid for a long time to get this. If that was so, you could have seen something more, maybe from a distance it's not easy, but could be an abdominal distension, hepatomegaly coming up, all of that. So we'll just keep in mind, see, in an exam you are going to be asked something of this kind. Today you have an exam in your own thing. So you go before the patient was admitted for examination. Isn't it? That's not a challenge. But this will be a challenge. Okay. So we
What
keep it
other
open. But
observations? Very good. So she is she's using her left hand, but she has not used her right hand in the 5-7 minutes that she's
what is
sitting.
the position of the both legs? Right external rotated right leg. So again suggests that right leg also could have had some. Could be.
Is she moving the leg or she not moving the leg? Right leg also. Okay.
She's supporting her right, not her left.
Okay. Which cranial nerve pulses can you make out? Facial you can make out. Which side? You have to give reasons why you are calling it a facial. Which nasolabial fold is less visible to you? Right is less visible. Hmm? Call her. What's her name?
Vibhuti.
Vibhuti.
Your facial is gone.
Vibhuti.
ठीक है ठीक है So right is quite well seen. So if at all the left is a little less seen, but we are not sure whether it's
So
a
cross semi-position. The left is doubtful.
Okay. What about third, fourth, sixth?
Because sit on this side, then you will be better off. Or because mother sitting on this side, likely to keep. It's a protective position.
You got something to attract her on her right. Okay. What about seventh
So
grade?
the point I was making is, if this was a cross thing, it would have been a lower motor neuron, and the eyes would have told you that it's an element. So the left side is not a problem. The head looks large, right?
Come on.
Yeah, I mean, we are talking about tuberculosis disease, intracranial, there's not be hydrocephalus, there must be a large head.
Say no.
This one
जोर से
stays.
बोलो.
Do you expect a large head at 4 years of age? In TBM, hydrocephalus? Why not? You mean the sutures are fused at 4 years? What age do the sutures fuse? Adults. So adolescents, okay. So then you would have seen a hydrocephalus at 4 years in TBM, right?
Sorry.
You see hydrocephalus, but it doesn't present as an increase in the density.
The fast growth of the skull is already over by then. So there is no much scope. And even with a hydrocephalus, you will not measure it as a large or macrocephaly. Yeah. So we already made out a right-sided weakness, okay, possibly without a fascial, which itself means that the lesion is at the spinal column. Look and it's a hemiparesis, so it's not cortical or subcortical. Okay, it's like an internal capsule, but there is no fascial, there's no other cranial down, come down to the spinal column. There could be something higher up also, but this hemiparesis is spinal.
Come on, answer.
Subcortical might explain this with facial spelling.
And
His subcortical would be asymmetrical largely. Okay, but we'll look at that, yes. So subcortical could be without
No dense hemiplegia. No dense hemiplegia.
fine. Any other explanation for no fascia? Recover, no? 1 month. Maybe it has recovered, you don't know.
But just to be on your side, there was no history suggestive of facial asymmetry noticed by the parents. So for discussion's sake, we can keep it that way because you have got a very nice,
Otherwise
detailed,
a very
otherwise
nice-
a good history.
And spinal vasculitis. We are thinking about vasculitis. So spinal vasculitis, the vessels are going all around. What Tushar said just now is that it's a small compartment. And except the tumor coming from, say, extradural will slowly progress to give you localized symptoms to become generalized. But not this. Therefore, it's certainly not spinal. Then why no facial at all? Can a cortical or subcortical have no facial?
Subcortical sometimes.
Okay, right.
Come on, now one of you want to examine.
I think
Or
quick
sometimes
thing
there's a frontal
shows the upper motor neuron signs. Anyone. Shows the tone, shows the reflex, shows the plantar, shows the flow.
चल बाय विभूति बाय मन चलो बाय
बाय बाय बाय का बस चलो आप जाइए चलो आप जाइए
मैं भी आता हूँ
चलो चलो इधर चलो 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 हाँ अभी जाएंगे ना चलो इधर से जाएंगे ना इधर है दरवाजा अपना दरवाजा किधर है चलो
अच्छा ठीक है मत चलो you could make out, right, that the right lower limb is circumflexing and right upper limb definitely paucity of movements, no swing.
Yes, one of you show the tone. Come on, anyone. I think tone looks to be so simple to be shown by somebody who is appearing next week for the final entry, right? Come on, anyone. Come.
Some class. Some more resistance across the inclusion. You are right about
Checking the flexor tone or the extensor?
when I flex, I'm checking the extensor tone.
Where do you expect the catch to be more prominent? While like the flexor tone or in the extensor?
Extensor tone is increased upper motor neuron region. So when the track goes flex.
What is the posture in upper limb? Hands like this. Yeah, that tone increase more in the flexor. Anti-gravity.
Anti-gravity.
Right. So in the upper limb it's the flexors, in the lower limb it's the extensor.
There is no plasticity across the wrist line.
In wrist joint, you should look at pronation, supination.
That's the first one to get affected. Adductors and pronator supine. Adductors of the hip. No, don't do that. So along with this, you should do the flapping movements and try to do leg rolling or hand rolling and try to touch the muscles and see whether they are flabby or not. Yeah. That's it. Yeah.
So hypotonia. Hypotonia. I can see that, isn't it? He wanted you to do that, active and passive muscle tone. It's hypotonia. You don't agree with hypotonia? You should again. Look at that.
Lose what pick? Lose what pick?
आता कडक केली
आता कर.
आता हे आपलं असं पकडलं ना आता बघा
Can a given patient have multiple types of tone abnormalities? Hypotonia, spasticity, dystonia, rigidity, or all in one? You showed us the hypotonia, and you showed us the plasmate also.
So the recovery may
So recovery should have a plasmate disappearing and a hypotonia coming up.
yeah, the hypotonia disappears and the spasticity gradually ensues.
So this hypotonia is nutritional and not neurological. Okay. So most of our patients will have this and also have plasmate. Okay. Thank you.
Also note that though the complaint started with the proximal muscles and then went on to the distal muscles. Right now, if you see her, this proximal movement is better, it's almost against gravity. Whereas at the wrist and elbow, at least on inspection, there is not much movement. At least not against gravity. I'm not sure it's involuntary. More like she's doing it on her own. Involuntary has to happen multiple times. Unless you say something like dystonia or something which will get precipitated on certain maneuvers.
Can upper motor and lower motor neuron signs occur together? Hypotonia and increase tone spasticity. It can only happen rarely in a neurometabolic disorder, where the central disorder may also have a peripheral nerve injury. And you might have a combination of some upper motor neuron signs and a lower motor neuron signs, but not in this acquired disorder.
ALS in adults, right? In pediatric. Community.
Just confirm that there is no raised ICT. Examine for raised ICT.
Headache, vomiting, and
No, clinical examination. Physical exam, fundus, what else?
raised BP, blood pressure.
So measurements.
you look in a smaller, right?
Measurements would be positive. Okay, sutures are not properly fused. Okay. So fundus is of course first, but measurements, yes. Even before the fundus can come in.
If you get actually mixed upper motor and lower motor, you sometimes also have to consider tubercle process, because along with vasculitis here, there could be arachnoiditis, or there could be a local nerve compression and subsequent problems. Also in meningomyelocele, sometimes in lower limb you can have upper and lower. And finally in subacute combined degeneration, B12 deficiency, one can have upper and lower motor signs on two different sides or in different areas.
Lowering.
Both are based, right?
Actually, for ankle, that is not the right position also to do this.
That's
ठीक है. Knee, what did you get?
Lower skin is sorry. Can't hold the muscle that you are going to expect. Even really possible in the knee.
Yeah. ठीक है. Thank you.
To elicit a clonus, you may have to change the position of the limb. Okay, you may not get it in one position. So you move the limb up and down to see whether you still get it.
So why is the extensor tone increased in the upper limb?
Right side
Why
with
is-
increased tone.
Increased tone in the upper limb. Increased extensor tone in the upper limb. In this side.
So it's a UMN lesion, no?
Flexor tone should increase in the upper limb.
Yeah. So between flexor and extensor, flexor you expect more. Now, here you can have, these tone, you can always have a lot of variations. But basically, increased tone is because of the UMN.
It looks like the plasma.
If it's not class match, sometimes you can attribute it to some extrapyramidal involvement simultaneously. And that's what Sir was saying, hypertonia, or more importantly, variable tone. That would go with dystonia also. Looking normal and suddenly when the child wakes up and you try to do it, then you get increased.
Somebody, a 4-year-old girl, birth and development. A 4-year-old girl, birth and developmentally normal child, immunized, brought with complaints of fever, seizure, and subacute onset, progressive, right-sided hemiparesis with upper limb more than lower limb involvement. So I felt like there was actually right up facial nerve palsy. I felt like there was slight deviation. Uh, Without other cranial nerve involvement, without signs of raised intracranial pressure, is most probably a case of vasculitis or space occupying lesion like tuberculoma or malignancy or thrombotic stroke involving the left MC.
Ma'am, sorry to disturb. Can you share again, please? Share screen.
Can you see the screen?
Yes, yes, sir. Summary.
Yes, we can see Rajesh.
Yes, thank
Yeah,
you.
yeah. Okay. Okay.
Investigations, complete blood count had a hemoglobin of 10.3, hematocrit of 28, total counts of 9,600, and platelets of 5,21,000. Microcytic hypochromic. Renal function tests were 7.6. We sent a detailed Cox workup for the child. And the MRI brain neuroimaging, which was done outside, had a provisional report of multiple conglomerated lesions in the left thalamic region with diffuse perilesional edema with compression of the left lateral ventricle with 4 mm midline shift. We get to get the final MRI report.
What Cox workup did you send?
We sent CBC with ESR. We did a chest X-ray. We did an ultrasound for retroperitoneal lymph nodes. We sent a gastric lavage for gene expert and Montu. We gave a Montu. We haven't done midline shift on the neuroimaging, so we didn't go.
How many days back?
This was done on 18th of December.
Fundus?
For this, there was no evidence of papilledema.
Family screen.
And family screening.
Why family screen?
To look for Cox contact if the child had exposure.
But anyway, this is tuberculoma. We are going to treat Cox contact or no Cox contact.
For the family, the other members.
Other members fine. I'm talking from patient point of view. You get my question? Child has tuberculoma. You are going to treat TB. Why do family screening? How will it change? And so further, so drug resistance. So if there is a
You do a family screening so that other members may have already caught up this infection. You are wondering whether he has got it from other members. I am worried whether the child will give it to other members. What is your comment on that? Both are likely.
now assume that there is a lung infection also for this child. Forget tuberculoma. You're not worried. You think tuberculoma will not pass on, but lung infection can pass. After all, what has gone in the brain has gone from somewhere. Open, communicative. Open means communicated. X-ray, no? 4.5-year-old, what open cocktail? You get one lymph node.
Children less than 5 years tend to have the severe course and more they can spread.
So what Sir's saying is that children usually do not pass on to other children or other adults. Adults pass on to and adolescents. When we say children now, we should say adults and adolescents can pass on to.
This parent have 1-year-old child. And now this 4-year-old child has to go through. Will you not screen the 1-year-old child, maybe even a CT scan or a GL? Because that child is at risk. If you miss it for the next 1 month, he will come with TB.
So it's important to do family screening for multiple reasons. One is to find out if there is any active adult member, because if you do not treat that adult member, even if you treat, you might get a reinfection. Second, more importantly, if that one has a drug-resistant TB, then you can assume or be more aggressive in finding a microbiological diagnosis for this patient. And as I said, for finding latent TB and then treating accordingly.
Your order, when you say full TB workup, it would be nice if you start with X-ray chest because that's the screening test instead of saying CBCS
and GL.
and GL. So X-ray and GL should come topmost. And
Means honestly, na, if the examiner wants to trouble you, they'll say where in NTEP it's written to do CBCS. Has it been written? No. When do you do SGPT? Before starting. Where is it? Where is mentioned? No, unless it's multi-drug resistant TB, if you're going to start treatment for drug resistant TB, you need to do the set of tests before starting drugs. For drug sensitive TB, you do not need to start unless you are suspecting drug induced liver injury. Thank you.
good.
Good. Why did this computer say 543 there?
We have to do a proper examination to confirm whether it's left or right facial. And we don't expect a left facial. No, we are not. The lesion doesn't seem to be which is likely to give a cross penetration. So that was just a misleading. You were not sitting properly, and also in a detailed examination, you would have confirmed that there's no left facial.
I think in an examination, if you get a patient who has already been treated for a few weeks, his facial would have got better. Okay. Have you seen the facial remaining permanently? If you've seen everything else remaining permanently, it is nature so kind so that your face is not destroyed. But Sharad Pawar has a permanent facial. Okay. So does it occur only in the senior citizens?
Huh?
That was oral cancer.
That was due to oral cancer.
What has oral cancer to do with facial? In other words, that was a lower motor neuron lesion. Okay. Here is an upper motor. But common is lower motor neuron lesion is when you're traveling by the train, there is a lot of draft coming. You might end up in a facial like this is not unusual and recovers completely. So why did Sharad Pawar's facial did not improve at all? And he must have got to the best of the doctors. Because are you concluding best of the doctors are not usually the best, but could be worst? But in other words, unless the facial is destroyed, it's only compressed, you have a good chance of recovery. And why should it recover? What physiotherapy? This I know. What kind of physiotherapy? Cybernetic stimulation. Correct? Who can you give facial, any physiotherapy? Can you move the muscle? And ask him to keep on chewing?
So when you frown, how many muscles
Yeah.
do you
When you are
use?
upset and you are frowning at me, you are using the facial muscles. Safe to keep on frowning, shouting, crying, you will never have a permanent facial. Right?
You use 64 muscles when you are frowning of the face.
Good evening, everyone. 2-year-old male child, second by birth order and born by third degree non-consensuous marriages, resident of the Jalgaon,
Please make full
hailing from
screen.
Maharashtra.
Stop sharing करके वापस. Can you see now, Anjali?
Yes, but not full screen.
It's your full screen here.
Okay.
2-year-old
Okay, we
male
can
child,
see.
second by birth order, born by third degree consensuous marriages, resident of the Jalgaon, hailing from Maharashtra, brought by parents with complaint of cough cold since 15 days, fever since 10 days, and increased work of breathing since 1 day. Then patient was apparently all right 15 days back. Then he developed cough, which was weird sounding, non-spasmodic, and not associated with postaciometers, cold in form of watery nasal discharge, and fever, which was undocumented, high grade as per mother, relieved on medication, not associated with rigors. Child was lethargic in between interfebrile periods. Then increased work of breathing in form of increased rate and depth of the respiration, and history of the lethargy and decreased oral intake present. In negative history, no history of the ear discharge or eye discharge, no history of the past admission for recurrent respiratory infection to rule out the heart disease or immunodeficiency, no history of the cold extremities or decreased oral intake to rule out shock, and no history of the coughs or coughs on time. Then for the above complaint, child was shown to the private practitioner. Radiological investigations were done and told to have respiratory infection and referred to the higher center for the further management. In past history, no history of the past admission. In ANC history, registered supplements were taken, TT injection taken, 3 USG scan done, told to be normal, and no history of the any pregnancy complications. Family history, no history of the similar complaints in the other member of the family. And birth history, full term, LSES, full term LSES, cried immediately after birth. Birth weight was 2.5 kg, and no history of any NICU stay. Immunization was up to date. Dietary history from the family pot. Complementary feeding started at 8 months of the age. In developmental history, gross motors runs and climb upstairs and downstairs with two-step posture. Fine motor is tribals and language, speak two word sentences. Social, parallel play, child developmentally appropriate for the age. Then anthropometry.
Go to the first. Okay, boss. You take it. Is now
Where?
come. So what do you make out of this? What do you make out of this story quickly? Come on. Infection or no infection? Viral or bacterial? Okay, why viral, why bacterial? Sorry?
Followed probably by secondary because viral infections usually do not last for so long.
Okay. So, sorry?
Child was lethargic.
So lethargic and lethargic.
I think when you have a fever, cold, cough, it's important to find out what the sequence of appearance of symptoms. If it's an infection, it's the fever first. But imagine somebody starts with cold, by next day starts coughing, and by third day gets fever. Is it an infection? You get the question. One child comes with high fever, the next day getting cold cough, viral infection. The other fellow gets cold first, then gets cough, and then gets fever. Is it also same? What's the difference? क्योंकि the parents would say क्या क्या होता है सर्दी खांसी बुखार है. They will have the sequence of appearance and even sometimes sequence of disappearance. So the typical viral infection, fever starts, cold and cough follows. By day 3, the fever is getting better. By day 4, cold is getting better and the cough is worsening. For the next 1 week, the cough continues. That's a typical viral infection. So what about cold, cough and then fever? So some reactive areas which may be getting infected if there is a high fever, like rhinosinusitis in the background of atopy, or maybe a mild fever, and that fever is just some inflammation and not an infection. So we need to be sure about what that really means. But here is a high fever. So did it start with high fever, or did the fever come later? Okay, fine. So high fever, cold cough together. The second thing is, anytime there is a cold and cough, you must ask whether it's the first time in life he's getting cold and cough. Because cold and cough is a very common recurrent symptom. And then you get on to again to annual disease, right?
So basically here there is a wet cough and the fever from whatever is being described is high grade with the child lethargic and all that. So this sounds like a bacterial infection, lower respiratory. The odd point is that cold. So we need to ask for exact details as Sir said. And sometimes when there's a past history of allergic cold, it confuses you because that cold is just there most of the time and this is a separate illness
So this is
altogether.
a ciliary dyskinesia. Okay. Upper respiratory, sinusitis, lower respiratory infection, cystic fibrosis, immune deficiency, but certainly not pneumonia. Sure, bolo. This is bacterial infection. Okay. So not pneumonia, that is certain.
So we don't know well grown or no, but from the history, apparently clean history till now. So that is an important point. But can it present for the first time any of these disorders at this age? Yeah, so it will be earlier onset usually, but it also depends on the severity of the problem. For example, cystic fibrosis can have a very wide spectrum. So you could have somebody who's presenting a little later and things like that.
Does pneumonia have a significant cough and cold? No. So this is not pneumonia at all.
So classic lobar pneumonia starts with high fever, followed by breathlessness, followed by cough later, right? So here probably we don't have a very accurate sequence of events, right? You don't know the exact sequence of events. So we will not be able to discuss that. Now increased work of breathing after some duration of fever. So fever was for how many days? 10 days. And then increased work of breathing on after 10 days of high fever. What do you think of this?
Initially viral fever, viral, it was viral fever, then bacterial, breathless, then viral.
Okay. So which viral infections will become secondarily infected and which patients will become secondarily infected? Okay, influenza, then adenovirus, then
Measles. Measles.
measles. Okay, then so as a principle, either the host is abnormal or the germ is very strong or debilitating, like typical example is measles, right? Or third category, when there is a local problem, like some obstruction, some congenital malformation, retention of secretions, blockage, all these things. So these are the categories who would get secondarily infected. Not every viral will get secondarily infected.
And I understand that we get this answer all the time about influenza becoming secondarily infected. And I'm nobody to comment on the guidelines, but the problem is that some guidelines mention to give antibiotic for influenza. But for all practical purposes, unless you are dealing with a severe influenza requiring hospitalization, only then you consider it as a secondary involvement. Otherwise, all of us see hundreds of influenza, whether swab through one or otherwise, we hardly ever have to give an antibiotic and certainly not consider secondary bacteria.
Adults give more often than in pediatrics. So pediatrics all get more. So now, what do you think of this increased work of breathing? Right. Yeah, increased work of. One you said was viral, then it became bacterial. That's why increased work of breathing. So you are saying it has become bacterial now. Now that means for 10 days it was viral, or 8 days it was viral. So that is also a little odd. So basically, we need a lot of accurate details in the history to fish this out. Any other thoughts? One thing that has not been mentioned is the treatment history. So whether this child was treated in those 10 days. Why do you think that makes a difference? Partially treated. So whether he has been getting some oral antibiotics and is half treated, we don't know. So any other thoughts for breathlessness on the 10th day? Should also keep complications in mind, right? So one you all said viral becoming bacterial. Second, you have to keep some complication happening in mind, which has made this child get. So since you know that no antibiotic was given.
Where is where is the anatomy of this breathlessness? Pulmonary ears, but what airway? Lung parenchyma. What lung parenchyma after 10 days of illness? That's funny, no? All those problems could have come up in 2 days, 3 days, 4 days. Why 10 days? Who gets breathless after 10 days of a respiratory problem? You agree to that? Okay. If it was an airway, it could have come up much earlier. If it is a lung parenchyma, maybe second, third day. Okay. So, where is the anatomy of this?
If it is not these two, then where can it be? pleura.
And therefore the question is, are we getting a complication of a pleural infection, which could take any time? Okay. And especially if it's a partially treated bacterial infection, not well treated, it could extend further to pleural. Okay. And therefore the question is, somebody who comes after that. But what is against typical pleural involvement in this story? Increased rate possible in pleura? Yes, of course. What about the increased depth? Does pleural disease give pleura? Pleura with breathlessness is pleural effusion. Okay. Does pleural effusion have an increased depth?
So then we are shallower breathing.
Okay. So that's something unusual. But I'm sure in the history you don't get all those details. Okay. That's your imagination of you have interpreted it what the mother has said. But one thing is certain that this anatomy looks more like a pleural than parenchymal or no interstitium. Interstitium is acute often or chronic is over weeks or months. So must be a pleural problem. Okay. But we are not sure at this point of time. Now, which pleural problem comes after a significant cold and cough? Pleural problem is a complication of pneumonia. Okay, pneumonia could be tuberculosis, pleural effusion, or even pneumonia. Okay, but bronchitis, after airway infection is bronchitis. It can have a lung parenchyma, but why should it have a pleural?
Pneumonic is following a lobar pneumonia. Sir is asking for a airway infection. How can it involve the pleura?
I know of an airway and a parenchymal infection, like intercellular organism. Could it be mycoplasma giving you a pleural complication? Mycoplasma has many immune complications, right? Hemolytic anemia, for example. So, are you considering this as an immune complication? So, I know TB often has cough, often has parenchymal disease, often has a pleural disease. Okay. Then mycoplasma may have, but not commonly pleural empyema or anything. No. The extrapulmonary complication, joints, hemolytic, but not this. So that's unlikely. So then we are not very sure where we stand. And again, like the first child, we must learn to ask many more details as we go about thinking. Okay. Doesn't matter. We are all learning how important is history to you. Okay. Otherwise we get confused. Okay. And why lethargy? Multi-system involvement. The previous one was also lethargic. For some 30-60 minutes he was lethargic. You call it post-event. This one is lethargic. So why is he lethargic? What is lethargy to know is breathlessness. I thought breathless people are very irritable. Okay. They're suffocating. How can they be lethargic? You can't be lethargic and breathing fast. Isn't it? You see a bronchiolitis, when you have a middle of the night a child admitted with bronchiolitis, you walk from your quarter, you can see him cry, or hear him cry. Irritability is an accompaniment of breathlessness, not lethargy. So this must be encephalitis.
चलो बोलो. Exhaustion. Then respiratory failure. Decreased oral intake. Then
Maybe decreased activity as compared to not proper
so why decreased activity? Bacterial infection itself will cause a decreased activity and toxemia, what we say, of the bacterial infection, right? This
So
is
all
not
that could be metabolic. Hyponatremia is an often association. So you can be drowsy, hypoperfusion, hypoxia, okay, toxemia, several reasons. Respiratory problem can have a recurrence.
anthropometry.
Weight is 8.8 kg between the -3 to -2 standard deviation. Length was 84 centimeter between the -2 to -1 standard deviation. Head circumference was 45 centimeter between the -3 to -2 standard deviation. Then mid upper arm circumference was 15 centimeter between -1 to 0 standard deviation, and bed for length was less than -3 standard deviation. Interpretation: severe acute malnutrition. In summary, 2-year-old male child brought by parents with complaint of fever, cough, cold, in birth and developmentally normal child, immunized till date, is a case of lower respiratory tract infection, to rule out bronchopneumonia, Walleri, and pleural effusion.
So I know she's a younger resident, but your comments on the babies. Seniors. Today there are many seniors here. Come on, come on. Take one by one bronchopneumonia. So clinical diagnosis of bronchopneumonia. How do you make? What is in favor of bronchopneumonia?
What is bronchopneumonia? Bronchitis plus pneumonia?
For bronchopneumonia, the increased scope of treatment should have come earlier.
Okay. First, sir is asking what is bronchopneumonia.
Go home and open Nelson. See the last page index. You find bronchopneumonia word, then we will discuss it again next time.
What is he trying to imply? Even Nelson does not know there is bronchopneumonia. How can you and me know about bronchopneumonia?
Bronchopneumonia is a medical version of double pneumonia.
No.
Kind of.
Yes, the radiologists call it bronchopneumonia. For us, it's bronchitis or pneumonia. But what is important is because of bronchitis, there could be some segments which seem to be collapsed. Small areas of atelectasis. Okay, that the radiologists call it pneumonia, and there is a bronchitis. So they call it bronchopneumonia. There is no bronchopneumonia. Either you have bronchitis or pneumonia. Right? If we have both of them, yes, immune deficiencies here, you have both of them. But it's not one disease. Anatomically, it's a separate disease. So we'll get right. But what is the difference between first two and the third one? So that we could say whether we could change the order or even not consider first.
Talk about Walry.
Is Walry an acute breathlessness or coming after 10 days?
Fine. So Walry is also not tenable here. What about pleural effusion?
Increasingly rate and depth of respiration. We discussed more of shallow breathing, chest feeling, breathing get more in case of pleural effusion.
Agreed, but we did say that ultimately the anatomy seems to be something pleural, possibly. And so the question is this a primary pleural effusion or secondary to something? So more likely secondary, less likely primary, right? So a complication being pleural collection of something is a possibility, right? So that's how you will discuss this. Yeah. For you, I am only praising you that you did honestly put down what you thought, which is good because this is the way you will learn, right? So don't feel bad that we are discussing this. But these are the reasons why a Walry or bronchopneumonia will not come as a DD. Right?
And he said the last phase of Nelson. I'm sure you have opened Dr. Nelson recently. I mean, up to the last phase is difficult. So that is right. Okay. Yes. But I think you have done a good job. Yes.
Yeah. So go on. Examination.
On examination, child was lethargic, sick looking, and heart rate was 140 per minute. Respiratory rate was 54 per minute. Saturation was 93% on the room air. Peripheral pulses well fed. Extremities warm. No pallor, icterus, clubbing, cyanosis, lymphadenopathy, edema. Then head to toe examination, head normal, anterior fundamental closed, face normal, chest normal, knee normal, genitals normal, skin normal. Then systemic examination, respiratory system on inspection, chest was normal in shape, no deformity. Trachea was central in position. Respiratory rate was 54 per minute. Then no evidence of dilated veins or visible pulsation or any cross swelling. Opaque impulse seen at fifth intercostal space in the mid-clavicular line. And on palpation, inspectory findings confirmed on palpation, trachea central in position, decreased chest movement on the left side, opaque slit palpable. Then on percussion, dull note present in the mammary, inframammary, axillary and infraaxillary region on the left side of the chest. And on auscultation, decreased breath sound in mammary, inframammary, axillary and infraaxillary region on the left side of chest. Other system, CVS S1 is to present, CNS tone power reflex is normal, and per of the soft non-linear.
Patient is here.
No sir, patient is transferred to pediatric surgeon.
What pleural effusion? This could be any other lung parenchymal lesion. Imagine atelectasis. Dimly breath sounds. Okay, impaired note. Typical, right? The pneumonia may not have a bronchial bleeding to begin with, or may not have a bronchial bleeding while recovering pneumonia. But atelectasis may not have a bronchial bleeding at all. So this must be atelectasis. Okay. After all, there was a lot of cough and cold. Cough and cold is not an accompaniment of a pleural effusion. It must be an atelectasis. Impaired note. No? Atelectasis impaired note, diminished heredity, no foreign sounds. Typical.
So see, we have always felt and thought that impaired and stony, dull and dull, all these are differences which you can't make out
In fact, you have never percussed a stone in your life. Okay. Nor I have done. How do we know stony dull? Okay. We can't be that dull to call anything stony or not stony. And stones are of also different consistency. So impaired, yes.
So basically, all consolidation, collapse, effusion will all have a impaired note, dull note, whatever you want to call it.
So tell me, why not? To me, it is atelectasis.
It was such a large area, midnight shift of the it was such a large area.
So one is there should be midline shift. What else?
Midline shift should be for pleural effusion. The question is which side is the shift? So here there is no mediastinal shift. No? So neither of the two. That's more difficult. Come on. This we have discussed until number of times. So the findings have to be correlated with surface and anatomy of the and in surface anatomy, you have a lobar distribution or a pleural distribution. What is lobar distribution? Right side anterior upper half is upper lobe, anterior lower half is middle lobe, and posteriorly is all lower lobe. This is memory, inframemory, axillary, all over. Therefore, this is not a parenchymal lesion, this is a pleural lesion. And therefore, this is a primary pleural disease. There is a parenchymal disease, none. There is a primary pleural infection.
And underlying parenchymal involvement.
Where is the clinical underlying? Nothing. Only signs of pleural.
The saturation is low. Saturation is low.
93. He's saying 93 is low, so there is a underlying parenchymal which is just now we are not able to make out.
In other words, you know primary pleural effusion. Sure.
Tuberculosis.
Tuberculosis also has a small subpleural focus which is not visible. But you are right, even here it's not visible. He is right. Can you have only a pleural effusion without lung lesion?
Malignancy of pleura.
What about hemorrhagic pleural effusion? You have to have a lung lesion.
Connective tissue disorders.
Correct. Can you have any lymphatic correction there? Okay, chylothorax. Would the lungs be normal? Yes. So we don't know whether it is a chylothorax or a hemothorax, but the story doesn't look like
Story of 10 days of fever and all
that.
that.
Why not chylothorax? Thoracic obstruction. You get a chylothorax. When you tap, you will get typically chyle.
How many patients you see?
And chylous effusion collects chyle slowly over time, and the child is malnourished. The child is malnourished. Yeah, child, no, yes. It's not the chylothorax.
He became breathless in one day, no?
And he has got cold and he has got fever. Chylothorax doesn't have any of them.
Why not dengue then? Sir said now only plural.
Because bilateral is to the
No. Everything yes. सास भी कभी बहुत वाला छोड़ेगा. Everything bilateral is unilateral sometimes. Then becomes bilateral.
So cold and cough, high fever, and thereafter this. So it has to be a lung lesion also. As he said, there could be a lung lesion.
And genuinely for dengue, don't say it has to be bilateral. Okay. For nephrotic, we may still buy it as bilateral. But for dengue, it can, and we all know that it's more commonly or at least asymmetrically large on one side compared to the other.
In investigation, used local suggestive of the left-sided moderate pleural effusion with multiple thin septae within. Right CP angle clear, then tapping done after prior consent and under receptive condition. 15 cc fluids tapped and sent for investigation. And pleural fluid RM, RBCs were 37 RBCs per cubic mm, and TLC were 1042 cells per cubic mm. Polymorphs 85, lymphocyte 15, protein was 5.2 gram per day. Then pleural fluid CS, no growth. CBC, HB was 6.4, hematocrit was 20, WBC was 31 K, and polymorphs was 50%, and lymphocyte was 45%. Platelet was 404 K. Then CRP was 262.7 mg per. Then X-ray chest suggestive of the severe blunting of the left CP angle and patchy homogeneous opacity in the left lung field.
You have the X-ray.
No, sir. X-ray was done outside. There was just reporting of X-ray. And CT report suggestive of mild to moderate left pleural effusion seen with underlying collapse consolidation of left lower lobe. The collapse lung has a inhomogeneous parenchymal involvement. Small consolidation with air bronchogram seen in superior segment of the right lower lung. Possibility of infective etiology.
Why did she tap only 15 and then child is breathless? You could have tapped high. Breathless child with pleural effusion. How can you just do a therapeutic tapping? You have just a diagnostic tapping. You should have tapped the entire fluid. Don't you agree with that?
Loculated fluid.
So the cause of then more so call the surgeon immediately, isn't it? He's breathless. So the point that he made was he's restless because of his lifestyle. And he's not restless because of his diffusion. Diffusion must have tipped in favor of a breathlessness coming up. Otherwise, the early tachypnea must have been overlooked. But the cough. So one thing more we have learned in this child is when there is a cough, you must ask how severe is the cough. This child is unlikely to have a severe cough. So we don't have an airway problem. We have a mild cough and a lung problem. And there we would have stayed away and go diffusion secondary to a bacterial pneumonia. Right?
TB or bacterial? Empyema? TB or empyema?
Yeah.
5 grams protein. Polypredominant 31,000.
What is tuberculosis empyema? I have not heard it. Empyema is bacterial, no? It is bacteria, yes, but not tubercle empyema. Empyema is first, no? You get first in TB or a straw colored fluid. Is there anything like a tuberculosis empyema? Nelson has said it. So,
Yeah, you were saying something.
Empyema is bacterial.
So for this generation, empyema is bacterial only. In some years back, when they used to see a lot of TBs, occasionally they saw TB.
see, when a tubercle disease, active disease, extends to the pleura, it becomes the tuberculous pleuritis. Whereas a common way, it's a immune response to some small tubercle focus that is never a first produced. And what is important, the tuberculous pleural effusion rarely leaves behind a permanent damage. Okay, whereas this fellow will remain with some permanent damage and you have to go in surgically to get out of it.
TB affusion is a subpleural bones complex which ruptures and you get an immunological response. And that's why it's thin, it's straw colored and sudden and large. So they come with pain, acute onset pain because of the pleural separation.
In pleural fluid, cholesterol was 90 mg per dl, glucose was 5 mg per dl, total protein was 4.1 gram per dl, albumin was 2.3 gram per dl, LDH was 6923 international unit per liter, the amylase was 11 international unit per liter.
No ADA done? No ADA? Please stop. Good.
In Light's criteria, pleural fluid protein by serum protein was 0.64. And then pleural fluid LDH by serum LDH 4.34. Pleural fluid LDH was more than two-thirds of the serum LDH, so it's exudating.
Just show this again. CBC.
In impression, 2-year-old male child with complaint of fever, cough, cold in developmentally normal child, anthropometrically severe acute malnutrition is a case of pneumonic pleural effusion, most common etiology being bacterial.
No, don't call it pneumonic pleural effusion. Call it empyema. There are thin septate and there is fluid, which is thick, 5 grams protein, 31,000 CWBC count. Say empyema.
So how will you manage this child quickly?
Oxygen supplementation, antibiotics. Oxygen supplementation, antibiotics.
Answer like ऑक्सीजन में जरा ऑक्सीजन दे देना, जितना देना है दे देना।
20% तो वैसे ही मिल रहा है।
With what device, how much, why?
Oxygen supplementation, go to my nasal drops. I would like to start with the IV fluids.
How much?
maintain the silent rooms and I will decide further according to the overall acceptance of the child. I would like to start with the third antibiotics program, the third generation, which is a cephalosporin. And once the culture reports come, I will decide further the allocation. And from surgical level for the other lines, acid treatment or labs.
So will you do ICD in this check? No point in ICD. No? This will, ICD won't help you. Good. Thank you.
You are going to conference. Are you going to conference?
Thank you, Pallavi.
Next Thursday. So we would like you to be here.
Good evening, sir. We could hear both the cases well. There were two cameras, one focused on the slide and one on the one taps the camera hota. And we could hear both the cases well. Thank you, sir.
I was busy. No, I moved now next to his house. My building is going for redevelopment, so we shifted. I've taken it into place very next to the house. So now we are.
Oh, I see. I know that. So this Thursday you are not here.
Yes.
So I told him because I want to understand anything like that. You give them that because even Doshi and because we have also training. Even if you're like 16 weeks.
Maybe we can stop recording.
Yes, ma'am. Doing the same.